Thank you so much, dear MC, for that kind introduction. So once again, to our most honored Schools Division Superintendent, Dr. Wilfreda D. Mongalos, to our SGOD Chief, Dr. Reynold Velos, to all our participants, the key division office personnel, to our dear clinic teachers, school heads, to the medical dental team of the Bulacan City Division, good morning. Once again, welcome to our virtual orientation on the COVID-19 vaccination program. So for today, we have a lot in store. So let me start right away. So we have 8 modules regarding the vaccination program. And today, my task is to discuss to you Module 1 or Microplanning. Now, why do we need to discuss this? It's because it's part of the plan of the DOH to involve us teachers for the vaccination program. So later on, we will see our role, and we will see also how the vaccination will go, how the process will go. So let me start. Microplanning. What is microplanning? Microplanning is a bottoms-up process of detailed planning carried out to determine local needs and ensure smooth and satisfactory vaccine implementation. Why is it important to do microplanning for the vaccination program? It is very important to do good microplanning to ensure that campaign objectives are reached and immunization strategies are well implemented at the service delivery points, either in the health facilities or in the communities. Second, it is important in order to ensure that adequate resources are mobilized and in place with expected results to be accomplished on time. And lastly, it is important in order to anticipate the challenges and maximize the use of limited resources in an efficient manner in the context of the COVID-19 pandemic. So, there are 12 critical steps for microplanning. I will describe here in brief the one up to the 12th step, and then we will go in detail later on. And some of these critical steps will be discussed further in detail in the upcoming modules. So for the step 1, the critical steps is to determine the number of eligible population for COVID-19 vaccination in your area. So this is very important so that we can minimize errors. Also, we need to determine the exact number of eligible individuals that needs to be vaccinated so that we can also provide enough vaccines and also enough vaccination teams to do the procedure. Next critical step is to identify the implementing units in your areas and the number of vaccination posts or sites and plot in an operational spot map. Next, number 3 critical step will be to identify the number of supervisors, vaccination teams, AEFI, ASI composite. AFI means adverse event following immunization, and ASI means adverse event of special interest. So these are the adverse events that takes place after the immunization of the individual. And then next, the 4th step is to assign teams and vaccines to an implementing unit or vaccination post. The 5th critical step is to estimate the vaccine requirement and the ancillary supplies needed. The 6th critical step is to identify the gaps in the cold chain capacity. So we all know that our vaccines are very sensitive to the temperature requirements. So we also need to identify the gaps in storing these vaccines. The next critical step is to ensure timely delivery of logistics. So when we have everything that we need to deliver them on time. And so the next step is to prepare a daily vaccination session plan. That's number 8. Number 9, we develop a communication plan and implement social mobilization and advocacy activities. So we are going to discuss these things in detail later on. Number 10 will be to prepare a supervision and monitoring plan and schedule. Number 11, critical step, is to prepare an AAFI management surveillance and response plan. And lastly, is to develop a waste management plan. So let us go now in details for the critical step number 1, to determine the number of eligible population for the COVID-19 vaccination area. So right now, DOH is doing this electronic immunization registry, and then they will utilize that data gathered during the profiling in determining the number of eligible population for the COVID-19 vaccination. Now, once the type of vaccine has been determined, which type of vaccine to be deployed, so we work closely with the DOH Central Office and the CHT in determining the final eligible population based on the inclusion and exclusion criteria as provided by the DOH guidelines. So once it's done, ensure that data in the electronic immunization register are complete, and then they triangulate the accuracy of the profiling data with existing data available in the LGU. Then they determine the eligible population per municipality and city. And then with that, they disaggregate the eligible population by barangay and or implementing units. So from the bigger data, they cascade it down so that they can hone into the barangay level of who are going to be vaccinated. So who will be vaccinated? Okay, so this guideline is the one used by DOH and WHO. So the first eligible population, number 1, would be the frontline health workers, and it's categorized into A, B, and C. So who are the frontline health workers? These are all health workers from the private and public sector currently on active practice or service, whether they are permanent, contractual, or job order employees or staff. And in letter A of category 1, you have in public, frontline health workers in public and private health facilities. And these are all those who are working in medical centers, hospitals, clinics, temporary treatment and monitoring facilities, or TTMFs, and treatment and rehab centers. It will also include those assigned in triage areas, outpatient departments, emergency rooms, wards, intensive care units, operating rooms, delivery rooms, laboratory, radiologic and pathology areas, rehab units, and among others. Inclusion in this category, those who are assigned as part of the disinfection or decontamination teams, medical social workers, and security guards of the above-mentioned facilities. So these are the people who belong to frontline health workers in letter A. For the letter B, frontline health workers, you have the public health workers, and these are all workers in the public health sector who are providing direct health services. So this includes all employees in the public primary care facilities, which includes the rural health units, city health offices, the LGU hired and DOH hired deployed, and then all health workers employed, deployed, or detailed in provincial health offices, centers for health development, and Department of Health Central Office and its attached agencies. This also includes LGU deployed designated hard contact tracers, but for these hard contact tracers, their papers or their documents have to be ensured that there are appropriate documents stating the deployment or designation. And then you have frontline workers for categories letter C. You have barangay health workers, including barangay health emergency response teams. And this includes all barangay health workers in active service, all active members of the BRIHERST, and lastly, for category D, other national government agencies, which include the Department of Social Welfare and Development, the SWD, and its regional and local counterparts, the Department of Interior and Local Government, the ILG, those hired by the ILG as contact tracers. You have the Bureau of Jail Management and Penology, all employees and health workers assigned in direct contact with persons deprived of liberties, such as jail officers, wardens, and guards, and the Bureau of Corrections or BUCOR under DOJ, which includes all employees and health workers assigned in direct contact with persons deprived of liberty also. And the next eligible population, number 2, will be the indigent senior citizens. So this will include all indigent senior citizens registered as determined by the Department of Social Welfare and Development. And the next will be the remaining senior citizens, and this includes all senior citizens not categorized as indigent, registered and as determined by the Department of Social Welfare and Development. The fourth will be the remaining indigent population, and these are all indigent population as determined by the DSWD. And the fifth will be the uniformed personnel, all enlisted uniformed personnel in active services under the Armed Forces of the Philippines, Philippine National Police, Philippine Coast Guard, Bureau of Fire Protection, and Citizens Army Force Geographical Unit, or GAFGU. So that's it for step 1. So once they have categorized and determined that the DOH will have this data already and chart them in this table where they compute for the regional population, which will be provided by the PSA, and then they will drill that down into percentages at the municipality or city level, so that they will know how many vaccines or how many vaccinees they're going to have. So with that, at the LGU level, they're going to categorize that also by barangay. So for example, you have barangay 1 here, so they are going to compute for the number of frontline health workers as categorized from A, B, C, D, and then they will put also there the number of in barangay 1, for example, barangay Poblacion. So they are going to compute all the indigent senior citizens, the remaining senior citizens, and the remaining indigent population. So all these numbers are very important and very critical in order to really plan of how to deploy the vaccines and the vaccinations team later on. So critical step number 2 is to identify the implementing units in your area and the number of vaccination sites or posts, and plot in an operational spot map. So for the COVID vaccination, they have this so-called fixed post vaccination strategy, meaning they are going to perform the vaccines in the fixed areas, and then the following shall be utilized as the implementing units. So this is where the posts or the vaccination centers will be. So you will have the medical centers, the hospitals and infirmaries, private and public. You will have the rural health units, and then health facilities of other government agencies, including AFP hospitals and facilities, BJNP or Bucor health facilities, and Deped clinics. So here you can see that Deped clinics will be included. So this is where our role comes, and then lastly you have here the private clinics. So we still don't have a memorandum of agreement regarding usage of Deped clinics, but we need to be ready for this if they were going to ask to use our clinics. So the implementing units may have several vaccination sites or posts within its vicinity. So for example, in one medical center or in one rural health unit, they can have various vaccination sites or posts. And each vaccination post shall have at least 3 or more vaccination and AFI or ASI composite teams. So that is how it's going to it's like having that broad picture of how it's gonna look like where the vaccination will take place. So to each LGU is going to, this is just a sample form, so they are going to map that out. Each LGU will need to map that out, what are their government hospitals present in the municipality, what are the private hospitals present, where are the rural health units and the health facilities and private clinics present, so that they can estimate how many vaccination teams are going to be placed and where the vaccines are going to be assigned in which facilities. So the LGUs may utilize this link map that is for the DOH in order to map out this clinic. So this blue thing, so these are, I suppose these are government owned facilities, rural health units, and also government hospitals. So if DOH has already have the mapping or the implementing units in the area, it would be easier to plan out how to distribute the vaccination teams and also how to assign the sites or vaccination sites for each of the patients or the vaccinees. Okay, so that is part the second critical step in planning, microplanning. The critical step would be to identify the number of supervisors, vaccination teams, AFI, ASI composite teams, and other personnel needed and available for the vaccination campaign. So here are the operational guidelines. So each vaccination team will be composed of 6 personnel. So for the screening and assessment, so each vaccination team, there will be two personnel for screening assessment, which could either be a physician, a nurse, or a midwife, and then 1 counselor, which could be an allied professional or volunteers from partner agencies such as teachers, social workers, and medical students. So they can ask us probably, or they will be asking us teachers to help in the vaccination team. No? So our role will be either as counselor or either the next one. After this, you have the vaccinator, nurse, or midwife, or either they're going to get teachers for these 2 or 1 or 2 documenter or recorder, and for the vital signs taking, which they categorize as it could be, they could ask for the help of midwives, BHWs, health staff, or the volunteers from partner agencies. So here we belong here, you know? You have teachers, social workers, or medical students. And then in addition to the vaccination team, there should be 1 supervisor, preferably a physician, for at least 3 vaccination teams. So if you have 3 vaccination teams, there should be 1 supervisor, which is preferably a physician that will be overlooking these 3 vaccination teams. And then each vaccination team should have 1 AFI composite team. So the AFI, or adverse event following injection, these are the ones who will be overseeing if there are side effects after vaccination. So this will be explained more in detail in the other modules, but let's take note that each vaccination team will also have an AFI composite team to watch over them for the patients who may have adverse reactions. And then there will be 1 monitor, which should be a paramedic, nurse, or a midwife, and 1 surveillance personnel, so which could be a surveillance officer, nurse, midwife, or a pharmacist. And then the other personnel needed in the implementing unit, we will also need to have the local officials, especially the barangay captains. Now, if the vaccinations will be done in rural health clinics, so we need to coordinate with this, also with the security personnel, the PNP, They need to watch over, especially in areas where there are some safety concerns, no? And then, of course, the drivers for the vaccination teams and other support staff, and safety officers probably with the barangay tanons and others, no? And then the personnel needed in the community or health facility, we also have this house-to-house strategy, and this is for information dissemination. So you have the social mobilizers, which has for the help for the BHWs, and the navigators and the transport, which includes the BHWs and local health officials. So critical step number 3 includes most of the human resources part of for planning of the deployment of the vaccination campaign and the vaccination team. No? So as you can see here, we could probably have a role as counselor or as documenter or recorder if they ask for our help. So it's possible that they will use teachers as part of the vaccination team, no? As described here. Yeah, probable siya. Okay, so that's why we are explaining this program by module in detail to you, so that if ever one of us teachers will be asked to join the vaccination team, at least you have an overview of how the flow of the vaccination program is going to be, and you will be aware of how to prepare because you already have an idea of how the microplanning is done. Okay, so again, one vaccination team, there should be one AFI or ASI composite team that should oversee them if there are adverse reactions. And then one vaccination team should cater at least 100 vaccines per day. So ang usa ka vaccination team day dapat maka-inject siya og 100 ka buok per day, no? And then the proposed daily vaccination schedule will be 8 a.m. to 5 p.m. with 15 minutes break in the morning and in the afternoon, and a 1-hour lunch break, no? So that's how it's the flow of the vaccination program. And then it's important that to develop a contingency plan to ensure the availability of sufficient number of human resources are available while considering the following. So human resources assigned for the COVID-19 pandemic response should not be utilized as part of the vaccination campaign teams. So katong ma-assign na ni dapat dili sila ma-appeal sa vaccination campaign, no? So lahi siya nga set of personnel in order to maximize their time as kaning sila mo perform the vaccination. And then also we need to have a contingency plan for the possibility of COVID-19 infection among the vaccination campaign teams, no? And then services offered in health facilities should not hampered because of the vaccination campaign. If so, just kept to a minimal. And then the possibility of workers experiencing side effects, whether it be mild or severe after vaccination, there should be a contingency plan for that if na sila side effects, no? So here is the sample form. So it's very detailed here. So this is just a summary of what was discussed earlier. So these are the personnel needed, no? So you have for the vaccination team, you have personnel needed for screening and assessment, for counseling, vaccinator, and a document reader. And then for the AFI and the ASI team, you have the monitor, a responder, and the surveillance personnel. And then one supervisor handling 3 vaccination teams. Okay, so we go now for critical step number 4, and this is to assign teams and vaccines to an implementing unit or vaccination post. So if you already have the number of eligible individuals plus the spot mapping or the mapping of available facilities, so we can already assign teams and vaccinees to an implementing unit. Now, so we already know the location and the number, so we can already assign them. So to determine the eligible population to be vaccinated in the implementing unit or vaccination post, so we already have that in critical step number 2. So assign frontline health workers and to facilities where they are employed or deployed. No? So frontline health workers will probably have to be vaccinated where they are employed. No? Just like what's happening now in Cebu City. So those who are working at the specific hospitals, they get their vaccinations at the hospitals where they are employed. And then for frontline workers or uniformed personnel employed or deployed in agency without any health facility, so they will be assigned to the rural health units, no? So kanang mga clinics na to sa barangay health centers, no? And also in the city health. And then for senior citizens and indigent population, assign them in a facility nearest from their residence. And this is to minimize their exposure, at least doon ra ang ilang i-travel if they are assigned to a facility that is nearest to them. So that is why it's very important to really map out who are eligible and also the location of the vaccination facilities. And then allocate teams based on the number of eligible population assigned to the implementing unit or vaccination post. And so once you have the number, you can already allocate these teams based on the eligible population in number. No? So here is an example of how they are going to assign the teams and vaccinees to an implementing unit. So say for example you have Barangay 1, B1. So the vaccination post, they have 2. So for example they have the RHU 1 and a private clinic 1. And then you have here the assigned eligible population. Let's say they have 5,467 eligible population to be vaccinated. So the number of vaccination teams required would be 8, but their number of available vaccination teams is only 4. So there is a gap of lacking 4 vaccination teams. And then once you have here also, you know the gap between the two. So if we know the number of eligible population and we can see a shortage of available vaccination teams as well as the available composite teams, at least the DOH can plan beforehand how many they need to fill in the gap, no? How many additional vaccination teams and how many additional composite teams and other supervisors are they going to require in order to serve all of the eligible population. So this is why microplanning is very important, so that there will be filling in of the gap so that they can execute the vaccination as fast and as efficient as possible. Okay, we go now to critical step number 5, which is to estimate the vaccine requirement and ancillary supplies needed. So I will not go very much into the details because these are very medical. So I'll just give you an overview. So for the logistics, so you have the vaccines, the diluents, the syringes, the mixing syringes, the AEFI epinephrine kits, for those who are going to have reaction. You have the safety collection box, the PPEs which are going to be worn by the vaccination team. You have the alcohols and the cottons, the vaccine carriers, vaccine refrigerators, you have thermal guns, BP apparatus, stethoscope and pulse oximeter, immunization cards, campaign forms and checklist, cot beds, ambulance. So all of these logistics are going to be planned and prepared beforehand. And DOH has a formula for this of how many they are going to prepare, no? Based on the eligible population. So we will not go into the details of this, which is not very relevant to our task. But suffice it to know that in order to really cater to the needs of everyone, so they have the formula for the certain logistical item which needs to be prepared, no? So this is very important. Now, critical step number 6 is to identify the gaps in cold chain capacity. So after you have the logistics already, now we all know that the COVID-19 vaccine is very temperature sensitive, so we need to keep it in a cold storage. So that's why we also need to identify the gaps in the cold chain capacity. So first, we need to see the refrigerators, no? So make an inventory of refrigerators and freezers. So specifying the model. So this is very detailed already, but suffice it to know that the cold chain capacity is very essential to the vaccination program, no? So you need to check for the refrigerators, for the electrical system, no? So check electrical system for reliability, accessibility, quality, and security. No? And then we need to check and prepare the vaccine carriers. These are the storage boxes, no? Which need to evaluate the number of cold boxes, the vaccine carriers, and coolant packs. So there had to be an inventory of the existing equipment at each healthcare facility where the vaccines are going to be temporarily stored. And then there should be temperature monitoring. So we need to assess the number and condition of the thermometer. Are they functioning well? Do they have the enough battery? No? So in order to monitor the temperature devices, and you also need to have the temperature monitoring sheets. So if we are going to be part of the vaccination team, so at least we already know that we also need to watch over for the temperature of the vaccine. So we need to help in making sure that these vaccines are stored in cold chain properly. So critical step number 7, once we already have all of the logistics and we all have the cold chain properly prepared and in the proper, already have the inventory, so we need to ensure timely delivery of logistics. So dapat mag-abot silang tanan at the specific timing para dili maddaot ang vaccines. Human resources, the logistics, and everything, they have to work hand in hand in order for the timely delivery of everything. No? So this is also very critical. So next, critical step number 8 is to prepare a daily vaccination session plan. So this is the daily itinerary for the vaccination team. So you have to plot the activities or assignment of each implementing unit or vaccination post on a daily basis. Include in the plan would be the identification of the teams required, the determination of the eligible population, this is step 1 now, assigned for the day, and the expected number of vaccinees to be vaccinated per day. So as we have mentioned earlier, so the projected would be 100 vaccinees per vaccination team. So if you have 3 vaccination teams, so you have a target of 300 vaccinees per day. And then determination of the transportation mechanism for the vaccinees and the teams. So even the transportation, you have to plan it out that there should be physical distancing, no, so that it should be considered in computing the transportation seating capacity required. And then lastly, to determine the resources needed for the vaccination post and its quantity. So if you know the eligible population, so you also need the needed resources for that specific vaccination post. So you bring the exact quantity, or including maybe some buffer for probable damages or spoilage of the packaging of the vaccines. So here is an example of a daily vaccination plan. So for example, there will be a date of vaccination for March 15. So vaccination will be, post will be hospital 1, then team 1 up to 3, then who will be the eligible population. You have frontline health workers, target of 300. So the transportation for the team would be 3 hired vans. Transport mechanism of the vaccines, so since it's already stored there, so there's none. And then the resources needed. So this is part of the planning for the microplanning. So we really need to go into the details, no, of what we have discussed earlier. Critical step number 9 is to develop a communication plan for community advocacy, social mobilization, partnership, and engagement. So we need to have a list of community leaders to proactively engage in advocacy or social mobilization. As we have mentioned earlier in I guess critical step number 2, we need the help of the barangay captains and the other human resources we mentioned earlier in order to really engage the people, no, to proactively engage everyone in the advocacy for this. No? So this will include the BHWs, our other barangay health workers, probably the PANUNs, and everyone else in the barangay, to mobilize everyone so that they will be convinced to have this vaccine. No? So we need to communicate with them also. Critical step number 10 would be to prepare a supervision and monitoring plan and schedule. No? So this is not our probably this will not be our task because teachers will only be to the vaccination team. But suffice it to know that there will be a per level supervising team. No? So I will just describe them. So you have the vaccination team supervisor, implementing unit level supervisor, and then for the LGU as a whole, you have the LGU level supervisor, and then you have the monitors and the independent monitors. So the role of the vaccination team supervisor, as mentioned earlier, one vaccination supervisor to 3 teams, right? So there is his or her role would be to visit the vaccination teams at least once a day for supportive supervision using the supervision checklist, then to compile vaccination team reports, analyze them and report to higher level, and then to review the team performance and undertake corrective actions if needed. So it is the role of the supervisor to really check if they have reached their target so that they can make adjustments if ever they fall short of their target. So he or she can, the supervisor can advise the teams what to do or what to adjust in order to reach the target of 100 vaccines per day. And then he reports that to the higher level, which will be the implementing unit level supervisor. And this goes on, up and up. Okay? So I will not go into the details because this is beyond our tasks as teachers. Then for the critical step number 11, this is to prepare an AEFI or ASI management. Again, AEFI means adverse event following immunization. So, and the other ASI means adverse event of special interest. So these are the probable events or side effects after the person has been vaccinated. So there is a standby composite unit for this. So first we need to, in order to plan how to deploy the composite unit, so we need to prepare the management and surveillance response plan for the composite team. So you have to determine how many AFI or ASI kits are required per vaccination post. So this will correspond to the number would probably correspond to the number of vaccination teams. And then ensure that each composite team has the following emergency equipment. So they need to have the BP apparatus, a stethoscope, the pen light, a stretcher, or cot bed. And then we need to identify beforehand the referral facility for each composite team and identify contact person in the referral facility and his or her contact number. So for example, the vaccination team is stationed at an implementing unit of the rural health unit. We need to identify beforehand where they're going to bring the patient if an adverse effect or adverse event occurs. So say for example, they need to get the number of the referral hospital beforehand so that if something happens, they can directly bring or they can immediately bring the patient with the adverse event to the hospital, and they can call the identified contact person beforehand so that the hospital will be ready once the patient will be there. And then, of course, we need to ensure that an emergency transport vehicle is on standby in the vaccination post. So this could be an ambulance or the barangay service or any government vehicle. There should be a standby transport vehicle just in case there is an adverse event that needs to be brought to the hospital. So here is the sample of the contents for the AFI-ASI kit based on the World Health Organization's SIA field guide. So I will not discuss this because these are very medical, but suffice it to know that there is a kit in order to manage if there is an adverse event, should there be any adverse event. No? So manage isolate, adrenaline, cortisone, etc. No? So I think for those who are of you teachers who are also nurses, you will understand what are the need or why we need this stuff. No? So this is very important in order to rescue someone who has an adverse event after or following injection. So for the response plan, so you need to also take note of the details for the response plan or the AFI management surveillance and response plan. So you have here the vaccination post, and then what is the number of composite team assigned, then the number of kits available, the equipment needed, where is your referral facility, who is the contact person for the referral facility, what are the contact details, and what is the assigned emergency transport vehicle. So before any vaccination should occur, the AFIS eye management team should already have this filled up, so that in case something happens or there is an adverse event, we can already contact and bring the patient directly to the referral facility with the contact details also of the contact person. Okay. And lastly, so we have critical step number 12, to develop a waste management plan. So this is that understanding the healthcare waste management system in general requires the proper planning and implementation of managing waste to be generated in a nationwide COVID-19 vaccination, considering the complexity of the nature of the vaccine. So proper handling, storage, collection, and disposal of the waste should be followed to ensure protection of the environment and the general public. And this will be discussed more thoroughly in Module 8. If you will be part of the invited who will become part of the vaccination team, as recorder or probably as counselor, just also put in your mind that we need to handle and dispose of the vaccine wastes properly, and this will be discussed more in detail in Module 8. So I won't go into the details to that. So I guess that's all. Thank you so much for your time, and God bless us all. Good morning again. Have a pleasant day.